So if you look at the drivers of healthcare disparities, there are many social and economic inequities that drive disparities. So we can talk about disparities, which is kind of the differences in the outcomes, the differences in mortality, for instance, and the inequities are the factors that drive those disparities. As we know, there is a persistent imbalance in supply and demand in heart transplant, and these data are slightly old, but pretty much the same. And we know that the number of patients who are waiting transplant far exceed those who receive organs. So each year, now it's over 4,000 patients are transplanted, but then we have more patients who are added to that list, so we never ever catch up. So there's always going to be an imbalance between supply and demand. And then we look to the right and we see the sad, sad state of heart failure, which is essentially a giant sinking ship with lots and lots of patients that's been riddled by arrhythmias and LV dysfunction, RV dysfunction. And you see the tiny little lifeboat here that is mechanical circulatory support and heart transplant really only has the capacity to help a certain number of people. Many complex factors can coalesce to impact access. So we're moving on to access. Just getting into the door is a point of access, and then once in, getting access to the treatment. And so we can see here that race, sex, insurance status, adherence, all of these things can create disparities in access. So let's look at insurance, because this is one of those things I think we feel that we know, but the question is, does insurance really affect access to transplants? So this is a retrospective analysis of heart transplant and LVAD evaluations between 2012 and 2016. This is looking at Medicare and Medicaid data in Georgia. And they examined the association of insurance type with treatment eligibility and one-year survival. And what they found in this study was, number one, that Medicaid patients tended to be younger, they were more often Black, that fewer comorbidities. So kind of an optimal patient in some senses for advanced therapies, being young with no comorbidities. But they found that Medicare and Medicaid predicted a lower odds of eligibility for heart transplant. They also found that Medicaid patients were less likely to receive destination therapy, VAD, and when they didn't receive destination therapy VAD, they had significantly worse mortality compared to those who did. Medicaid was also a predictor of lower survival, and those patients who were not listed for heart transplant despite having fewer comorbidities. This is a study, again, by Dr. Breathitt, who has done work in the area of healthcare equity and advanced heart failure therapies. And she's done 2 of these studies. This is one where she attempted to determine how much race influenced decision-making for advanced therapies. What she did find was that race did impact every step of the decision-making, sometimes in a good way, sometimes in a bad way. So there was concern, for instance, that the photos might contribute to negative racial bias. There was some participants developed negative reactions to the white patient, but not to the Black patient. There were concerns about adherence, greater concerns for adherence for the Black patient versus the white patient, and so on and so forth. They're all listed there. There was a tendency in healthcare professionals who were 40 and older to oppose heart transplant in Black patients, and there was a trend. So it may be age-related, I guess, in our profession. But what we did find out, I think this was kind of an initial step at looking at the evaluation process and decision-making and just opening the conversation. So we know that transplant rates have increased overall. The new policy was designed to increase transplant. But is this true for all? So when they looked at the likelihood of transplant by race, we saw that Blacks were significantly less likely to be transplanted, even after adjustment. Waitlist death seemed to be a little bit less, and significantly so in Blacks, but post-transplant deaths seem to be significantly higher. So we're still seeing some disparities in getting to transplant, and also post-transplant outcomes. So if we move down to here, this is heart transplant rates. Your access to transplant not only depends on all of the things I mentioned before, but it also depends on where you are in the country. You may be at one of those centers where the transplant rate is very high and your wait time is very low, and therefore you survive, you make it, and everything is good. Or you might be in one of those states where the transplant rate is excessive, and you can see as it gets darker, the transplant rates are lower. So moving over here, these are pre-transplant mortalities based on geographic region. So your wait list death, that also varies pretty significantly by region, from about 5.9 or 0 in some places, all the way up to 44.6. So which state would you rather be in waiting for your heart transplant? But many times our patients don't have a choice. You are where you are, and you just have to wait. And again, another way to look at heart transplant rate is heart transplant within 1 year. So this is basically looking at the number of heart transplants per 100,000 population divided by age-adjusted heart failure mortality. So what she found was that Blacks had lower heart failure, heart transplant mortality ratio compared to whites, and Hispanics were pretty similar. You can see the greatest disparities in the Midwest. And again, factors that might be beyond the patient's control, such as wait time and access to organs.